Coronary Artery Disease, Chapter 34, Review from Class of the Lewis Textbook. Coronary artery disease is commonly referred to atherosclerosis, which is a hardening of the arteries. Although this condition can occur in any artery of the body, the atheromas, the fatty deposits, prefer the coronary arteries. The terms arteriosclerotic heart disease, cardiovascular heart disease, ischemic heart disease, coronary heart disease, and coronary artery disease all describe this disease process. Atherosclerosis is a major cause of coronary artery disease. It is characterized by deposits of lipids within the intima of the artery. Endothelial injury and inflammation play a central role in the development of atherosclerosis. The endothelium is normally non-reactive to platelets and leukocytes, as well as coagulation, fibrinolytic, and complement factors. The endothelial lining can be injured, though, as a result of tobacco use, hyperlipidemia, hypertension, toxins, diabetes, hyperhomocystinemia, infection, and causing a local inflammatory response. Fatty streaks are the earliest lesions of atherosclerosis and are characterized by lipid-filled smooth muscle cells. As streaks of fat develop within the smooth muscle cells, a yellow tinge appears. Fatty streaks can be seen in the coronary arteries by age 15 and involve an increasing amount of surface area as someone ages. The fibrous plaque stage is the beginning of progressive changes in the endothelium of the arterial wall. These changes can appear in the coronary arteries by age 30 and increase with age. Once endothelial injury has taken place, lipoproteins, which are the carrier proteins within the bloodstream, will transport cholesterol and other lipids into the arterial intima. This results in a narrowing of that vessel lumen and a reduction in the blood flow to the distal tissues. The final stage in the development of the atherosclerotic lesion is the most dangerous. As the fibrous plaque grows, continued inflammation can result in plaque instability, ulceration, and rupture. Once the integrity of the artery's inner wall is compromised, platelets accumulate in large numbers, leading to a thrombus. The thrombus may adhere to the wall of the artery, leading to further narrowing or total occlusion of the artery. C-reactive protein is a protein produced by the liver and is a nonspecific marker of inflammation. It is increased in many patients with coronary artery disease. The level of the C-reactive protein rises whenever there is systemic inflammation, and chronic elevations are associated with unstable plaques and the oxidation of low-density lipoprotein cholesterol, further contributing to the atherosclerosis. Normally, some arterial anastomosis or connections are termed collateral circulation exists within the coronary circulation. When a plaque occludes a normal flow of blood through a coronary artery and the resulting ischemia is a chronic increased collateral circulation then will develop. When occlusions of the coronary arteries occur slowly over a period of time, there's a greater chance of adequate collateral circulation developing, and the myocardium can still receive an adequate amount of blood and oxygen. But with rapid onset of coronary arterial disease, like with familial hypercholesterolemia or coronary spasms, time is inadequate for collateral development. So consequently, a diminished blood flow results in a more severe ischemia or infarction. Risk factors or characteristics or conditions that are associated with high incidence of the disease associated with coronary artery disease are categorized as non-modifiable or modifiable. The incidence of coronary artery disease in MI is highest among Caucasian middle-aged men. Most women have atypical symptoms of angina rather than MI when presenting with their initial cardiac event. Family history is a risk factor for coronary artery disease and an MI, and most times a patient with angina or MI can name a parent or sibling who has died of coronary artery disease. Modifiable risk factors are elevated serum lipids, elevated blood pressure, tobacco use, physical inactivity, obesity, diabetes, metabolic syndrome, psychological states, and elevated homocysteine levels. For lipids to be used and transported by the body, they must become soluble in the blood combined with proteins. Lipids combine with proteins then to form lipoproteins. Lipoproteins are vehicles for fat mobilization and transport and vary in composition. They are classified as high-density lipoprotein and then low-density lipoprotein and very low-density lipoproteins. So a high serum HDL level is desirable and lowers the risk of coronary artery disease. Low-density lipoproteins contain more cholesterol than any of the lipoproteins and have an attraction for the arterial walls. Elevated LDL levels correlate most closely with increased incidence of atherosclerosis and coronary artery disease, so a low serum LDL level is desirable. The second major risk factor in coronary artery disease is hypertension, which increases the risk of death from coronary artery disease tenfold. The stress of an elevated blood pressure increases the rate of atherosclerotic development. This relates to the shearing stress that causes endothelial injury. Therapeutic lifestyle changes should begin in people with pre-hypertension, the 120 to 139 over the 80 to 89 millimeters of mercury. Those with stage 1 or 2 hypertension often require more than one drug to reach those therapeutic goals. Third major risk factor is tobacco use. The risk of developing coronary artery disease is 2 to 6 times higher in those who smoke, and the risk is proportional to the number of cigarettes smoked. Changing in lower nicotine or filtered cigarettes does not affect the risk. Nicotine in tobacco smoke causes catecholamine, which is the norepinephrine and epinephrine release. These neurohormones cause an increased heart rate, peripheral vasoconstriction, and increased blood pressure, and these changes increase the cardiac workload. Tobacco smoke is also related to an increase in LDL level and a decrease in HDL level and release of toxic oxygen radicals. Carbon monoxide, a byproduct of combustion found in tobacco smoke, affects the oxygen carrying capacity of hemoglobin by reducing the sites available for oxygen transport. The effects of an increased cardiac workload combined with the oxygen depleting effects of carbon monoxide significantly decrease the oxygen available to the myocardium. There is also some indication that carbon monoxide is a chemical irritant and causes injury to the endothelium. The benefits of smoking cessation are dramatic and almost immediate. The use of illicit drugs such as cocaine and methamphetamine can produce coronary spasm resulting in myocardial ischemia and chest pain. Most people who are seen in the ED with drug-induced chest pain are initially indistinguishable from those with coronary artery disease. Although MI can occur, these patients most often have sinus tachycardia, high blood pressure, angina, and anxiety. Physical inactivity is the fourth major modifiable risk factor. It implies a lack of adequate exercise on a regular basis. Physical active people can increase their HDL levels, and exercise improves thrombolytic activity, which reduces the risk of clot formation. Exercise may also encourage the development of collateral circulation in the heart. In addition, adding weight training to an exercise program 2 days a week can help treat metabolic syndrome and improve muscle strength. Examples of moderate physical activity include brisk walking, hiking, biking, and swimming. Regular physical activity contributes to weight reduction, reduction in the systolic blood pressure, and in some men more than women, an increase in HDL cholesterol. The mortality rate from coronary artery disease is statistically higher in obesity. The increased risk is proportional to the degree of the obesity, and evidence points that people who tend to store fat in the abdomen, an apple figure, rather than the hips and buttocks, a pear figure, have a higher incidence of coronary artery disease. As obesity increases, the heart grows and uses more oxygen. In addition, there is an increase in insulin resistance in obese individuals. The patient with diabetes will show symptoms of coronary artery disease not only more frequently, but also at an earlier age. So a person with diabetes has an increased tendency toward endothelial dysfunction, and this may account for the development of the fatty streak seen in these patients. Metabolic syndrome refers to the cluster of risk factors for coronary artery disease where the underlying pathophysiology may be related to insulin resistance. These risk factors include obesity as defined by the increased waist circumference, hypertension, abnormal serum lipids, and an elevated fasting blood glucose. When the demand for myocardial oxygen exceeds the ability of the coronary arteries to supply the heart with oxygen, myocardial ischemia occurs. Angina or chest pain is a clinical symptom of reversible myocardial ischemia. Either an increased demand for oxygen or a decreased supply of oxygen can lead to myocardial ischemia. The primary reason for insufficient blood flow is that narrowing of the coronary arteries by atherosclerosis. For ischemia secondary to atherosclerosis to occur, the artery is usually blocked or stenosed 75% or more. On the cellular level, the myocardium becomes hypoxic within the first 10 seconds of coronary occlusion. In ischemic conditions, cardiac cells are viable for approximately 20 minutes. With restoration of blood flow, aerobic metabolism resumes and contractility is restored and cellular repair begins. Myocardial cells are deprived of oxygen and glucose needed for aerobic metabolism and contractility. Anaerobic metabolism begins and lactic acid accumulates. Lactic acid irritates myocardial nerve fibers and transmits a pain message to the cardiac nerves and upper thoracic posterior nerve roots. This accounts for the referred cardiac pain to the shoulders, neck, lower jaw, and arms. Although most of the pain experienced by people with angina appears substernally, the sensation may occur in the neck or may radiate to other locations, including jaw, shoulders, and down the arms. Often people will complain of pain between the shoulder blades and will dismiss it as not being heart-related. Chronic stable angina refers to chest pain that occurs intermittently over a long period with the same pattern of onset, duration, and intensity of symptoms. The pain usually lasts for only a few minutes and commonly subsides when the precipitating factor is resolved. Pain at rest is unusual. A 12-lead ECG often shows ST segment depression and/or a T-wave inversion indicating ischemia. The ECG can return to baseline when the pain is relieved. Chronic stable angina is controlled with medications on an outpatient basis. Because it is often predictable, the drugs are timed to provide peak effects during the time of day when angina is likely to occur. For example, if angina occurs when rising, then the patient can take the drug as soon as they wake up and wait 30 minutes to an hour before engaging in activity. Silent ischemia refers to ischemia that occurs in the absence of any subjective symptoms. Patients with diabetes have an increased prevalence of silent ischemia. This is most likely due to a diabetic neuropathy affecting the nerves that innervate the cardiovascular system, and silent ischemia is documented by ECG changes. Nocturnal angina occurs only at night, but not necessarily when the person is in the recumbent position or during sleep. Angina decubitus is chest pain that occurs only while the person is lying down and is usually relieved by standing or sitting. Prinzmetal angina often occurs at rest, usually in response to spasms of the major coronary artery, and the spasms may occur in the presence or absence of coronary artery disease. Prinzmetal angina is not usually precipitated by increased physical demand. Strong contractions or spasms of the smooth muscle in the coronary artery results from increased intercellular calcium. Factors causing coronary artery spasms include increased myocardial oxygen demand and increased levels of certain substances like tobacco smoke, alcohol, amphetamines. When spasms occur, the patient experiences angina and transient ST segment elevation. In microvascular angina, chest pain occurs in the absence of significant coronary atherosclerosis or coronary spasms, especially in women. In these patients, chest pain is related to an MI associated with abnormalities of the coronary microcirculation. This is known as coronary microvascular disease, and it affects the small branches of the distal coronary arteries, whereas the coronary artery disease affects the larger coronary arteries. In coronary microvascular disease, plaque can be diffuse, evenly distributed, or develop as blockages in the tiny coronary arteries. So prevention and treatment of coronary microvascular disease follows the same recommendations as for coronary artery disease. After a detailed health and history exam, a chest X-ray is done to look for cardiac enlargement, aortic calcifications, and pulmonary congestion. The 12 lead is obtained and compared with previous tracings when possible. Certain lab tests like lipid profile or diagnostic studies like echocardiogram are done to confirm coronary artery disease and identify specific risk factors. A calcium scoring screening heart scan locates calcium deposits in the atherosclerotic plaque in the coronary arteries. Additional testing, like stress testing, is needed to know the impact of the lesion on coronary blood flow. Exercise stress testing and pharmacological nuclear imaging are also helpful. So for patients with increasing symptoms or with a significant amount of myocardium that is ischemic under stress, a cardiac catheterization is ordered. Cardiac catheterization and coronary angiography provide images of the coronary circulation and identify the location and severity of any blockage. If a coronary blockage is amenable to an intervention, then coronary revascularization with an elective percutaneous coronary intervention, otherwise known as PCI, is done. During this procedure, a catheter with an inflatable balloon tip is inserted into the appropriate coronary artery. When the blockage is located, the catheter is passed right through it, and the balloon is inflated, the atherosclerotic plaque is compressed, resulting in vessel dilation. This procedure is called balloon angioplasty. Intracoronary stents are often inserted in conjunction with the balloon angioplasty, and the stents are used to treat abrupt or threatened abrupt closure and restenosis following the balloon angioplasty. A stent is an expandable mesh-like structure designed to keep the vessel open by compressing the arterial wall. Because stents are thrombogenic, anticoagulants are used during a PCI to help prevent the abrupt closure of the stents, like heparin, Angiomax, or Aggrastat. After the PCI, the patient is treated with a dual antiplatelet agent, like Brilinta and aspirin, until the intimal lining can grow over the stent and provide a smooth vascular surface. Many stents are drug-eluting stents. This type of stent is coated with a drug that prevents the overgrowth of new intima, which is the primary cause of stent restenosis. Patients with this type of stent may be on antiplatelet drugs for 12 months or longer, and the various complications from stent placement are abrupt closure and vascular injury. This picture shows A demonstrates an occluded coronary artery. B shows the same artery now open after a PCI and stent placement.